All right, let's talk about one of the absolute workhorses of your clinical toolkit as a new psychiatry resident, fluoxetine. You're going to see it, you're going to use it, so let's make sure you're ready.
So picture this. You're on call, you've got a new patient with major depression, and you're thinking an SSRI is the way to go. Is fluoxetine the right call? Well, by the end of this, you're not just going to have an answer. You're going to feel totally confident writing that script and presenting your plan.
So here's our game plan. We're going to walk through the whole journey, right? First, why even pick fluoxetine in the first place? Then, we'll get into the nuts and bolts of starting and adjusting the dose. After that, we'll tackle common side effects, cover the really critical safety warnings, and wrap up with some killer pearls for talking to both your patients and your attendings.
Okay, first things first. Who is the perfect patient for fluoxetine? You know, every medication kind of has its own personality, and figuring out fluoxetine's profile is really the key to matching it with the right person.
Look, we all know the basic deal with SSRIs, right? They block that serotonin reuptake pump, which boosts the serotonin signal. Simple enough. But what makes fluoxetine so different isn't what it does, it's how long it does it for. Its pharmacokinetics are really unique, and that's what sets it apart from all the others in its class.
And that brings us to the central trade-off with fluoxetine. It's kind of like a double-edged sword. On the one hand, its super long half-life is amazing for patients who might not be perfect with their adherence. You know, they miss a dose here and there. It's also known for being pretty activating, which is a huge win for someone with really low energy. But on the flip side, that exact same long half-life means you need a really long washout period if you want to switch to certain other meds. And that activating property, yeah, probably not your first choice for a patient who's already struggling with a ton of anxiety or insomnia.
So, where does fluoxetine really shine? What are its greatest hits? Well, it's a go-to FDA-approved choice for major depressive disorder and OCD. And here's a key differentiator. It's also approved for bulimia nervosa, usually at a higher dose. Those are the big three where you'll be thinking about it most often.
Okay, so you've picked your patient, you've decided fluoxetine is the move. Now for the practical stuff. How do you actually start it? The key word here, more than with any other SSRI, is patience. Seriously. We can break it down into 3 pretty simple steps. Step 1, you start with 20 milligrams once a day, and you'll usually give it in the morning to take advantage of that activating effect. Step 2, you wait. This is the hardest part. You've got to give it a few weeks to really see what it's doing. Step 3, if you need to, you can start titrating up, generally aiming for a max dose around 80 milligrams a day for depression or OCD. And if you're wondering why we have to be so patient, this quote from Stahl's Prescriber's Guide really nails it. Fluoxetine and its active metabolite, norfluoxetine, they just hang around for a really, really long time. This means it takes weeks for the drug levels to build up and stabilize in the blood. So trying to rush the titration isn't going to help your patient feel better faster. It's probably just going to increase the side effects.
All right, let's talk troubleshooting. Sooner or later, your patient's going to call with a side effect, and being ready for that call is what makes you a great prescriber. So let's get you ready.
You'll definitely want to give your patients a heads up about these right from the start. The most common stuff you'll see are GI issues, like nausea or diarrhea, and some CNS effects like insomnia or feeling a bit jittery or agitated, especially in the beginning. And of course, sexual dysfunction is a known side effect for all SSRIs, and it's really important to ask about it directly because patients often won't bring it up on their own.
So here are a few classic moves for managing those side effects if they stick around. If that activating effect is causing insomnia, adding a low dose of trazodone at night can be a huge help. For sexual dysfunction, augmenting with bupropion is a really common and often effective strategy, probably because its dopamine and norepinephrine action can help offset the SSRI effects. The point is to have a specific evidence-based plan ready to go for these common problems.
Okay, let's shift gears to something absolutely critical. This is the section you cannot forget. While fluoxetine is a safe drug overall, there are a few major warnings and interactions that you have to have on your radar.
If there is one number you burn into your brain about fluoxetine, it is this one, 5 weeks. If you need to switch a patient from fluoxetine to an MAOI, a monoamine oxidase inhibitor, you have to wait at least 5 full weeks after they stop the fluoxetine. Why? Because of that crazy long half-life we keep talking about. If you combine them too soon, you risk a potentially fatal serotonin syndrome. It's a huge deal.
And here's another absolute non-negotiable, a hard stop. Do not prescribe fluoxetine with pimozide or thyrazidazine.
Fluoxetine can block the enzymes that break these drugs down, which can lead to dangerously high levels, prolong the QTC interval on an EKG, and put the patient at risk for life-threatening heart rhythms. Just don't do it.
Beyond those big ones, you also have to remember that fluoxetine is a moderate inhibitor of a couple of key liver enzymes, CYP2D6 and CYP3A4. What does that mean for you? It means it can jack up the levels of a lot of other drugs. We're talking certain tricyclic antidepressants, beta blockers like metoprolol, even some benzos like alprazolam. The bottom line is, always run an interaction check.
So you've done the hard work, you've made your clinical decision. Now you have to communicate it, and you have to do it effectively, both to the person who's actually taking the pill and to your supervising attending.
So when you're presenting to your attending, here's how you sound like a rock star. You frame that half-life as a deliberate choice. You can say something like, I chose fluoxetine specifically because its forgiving profile will benefit this patient who has had some adherence challenges, and I'm aware this means we'll need a 5-week washout if we ever switch to an MAOI. See? It shows you thinking 2 steps ahead.
Here's another one of those high-yield pearls. You know your attending is going to ask, so why fluoxetine over sertraline or escitalopram? This is your answer. You say, I specifically chose it to target the patient's energic symptoms of fatigue and low energy. Boom! That shows you're not just picking a drug, you're doing thoughtful, symptom-targeted psychopharmacology.
And for your patient, keep it super clear and simple. Here's your checklist. Let them know it can take several weeks, maybe even a month or more, to feel the full benefit. Give them a heads up about the common initial side effects and reassure them that they often get better with time. Remind them to take it in the morning. And, critically, tell them never to stop it suddenly without talking to you first.
So let's bring it all home. Fluoxetine is not just another SSRI on the list. It's a very specific tool with a very distinct profile of strengths and, yeah, some risks. Your job is to be that skilled clinician who knows exactly when to pull it out of the toolbox and how to use it right. So as you get back to your day, think about your patient list. Who on there might just be that perfect candidate?